Grace is a mother, a wife, a partner, a sister, a daughter, a friend. Unable to see the storm brewing inside her body. A body beginning to send signals that there's a problem. Symptoms like bloating, upset stomach, frequent urination, and abdominal pain were never taken seriously, so she sought a second opinion. And a third. And a fourth. When the pain was so severe, she was sent to the hospital for extensive evaluations. Evaluations that weren't routine in the countless offices she had visited. She was diagnosed with stage 4 ovarian cancer. Like so many women, Grace went undiagnosed for far too long. If Grace had been diagnosed in stage 1, when the storm was building, she would have had a 91% chance of surviving. At stage 4, women face a 27% survival rate. It's time to quiet the storm. What if women could be routinely screened for ovarian cancer? What if early ovarian cancer indicators could be found in common pap smear-like tests? Or with using implantable nanosensors, or in new technology yet to be explored? What if early-stage detectors could be seen within biomarkers in a simple drop of blood? No more what-ifs. With your support, we now fund more than 11 early detection research projects annually, including projects in clinical studies and trials. We are closer than ever to making Tina's wish come true. The ability to save 150,000 mothers, wives, partners, sisters, daughters, and friends globally just like Grace every year. Together, we do more. No early, no hope. Join us today at tinaswish.org.
Hi, everyone, and welcome to the Tina's Wish EmpowHER Webisode, Ovarian Cancer, Facts and Figures in honor of Ovarian Cancer Awareness Month. My name is Rachel Nix, and I am an actress, fierce women's advocate, mirror trainer, doula, and Lululemon ambassador. Before we get started, I would love to give a big thank you to our EmpowHER sponsoring partners and community partners. We are honored to join forces on this program and provide critical information about ovarian cancer. Tina's Wish funds cutting-edge research for the early detection and prevention of ovarian cancer. Throughout this program, you will learn more about why this work is so critical. As you've heard, the goal of EmpowHER is for all viewers to walk away with a new toolkit of helpful knowledge. The EmpowHER Webisodes cover many interesting topics about gynecologic health, feature subject matter experts, offer closed captioning in English and Spanish, and are 30 minutes in length. To view closed captioning, click the English or Spanish button under the live stream on the event website. Para ver los subtítulos, tan solo haga clic en el botón de inglés o español que se encuentra justo debajo de la transmisión en vivo en la página web del evento. This is an inclusive journey, and we are honored to have all of you here with us. Throughout the program, please feel free to type your questions into the chat box next to the live stream, and Tina's Wish will address these questions in their follow-up email. Now, I am so pleased to welcome and introduce our panelists. Dr. Bhavana Pothuri, a gynecologic oncologist, NYU Langone's Perlmutter Cancer Center, and Dr. Leslie Randall, a gynecologic oncologist at VCU Health. I am so excited to be here with both of you. Let's get started. In honor of celebrating Ovarian Cancer Awareness Month this month, can you please explain to our audience why it is so important that we have this conversation? Dr. Randall?
Thanks, Rachel. I'm so glad to have this conversation. It's important to talk about it because people don't talk about it, right? You don't really hear ovarian cancer come up in everyday language. You see breast cancer all over the place. You see pink ribbons all over, but you just don't really hear much about ovarian cancer. And that's because luckily it's fairly rare in the United States, but it's still common enough and serious enough that it's great that we're talking about it today.
All right, Dr. Pothuri, let's start with you. If you could cover some key statistics around ovarian cancer.
Ovarian cancer, there are about 20,000 new cases of ovarian cancer estimated in the United States in the year 2022. There are about 13,000 estimated deaths from ovarian cancer. Ovarian cancer has actually accounted for the majority of gynecologic cancer deaths, representing over 50%. But we are seeing that endometrial cancer mortality is now kind of creeping up and kind of almost equaling that of ovarian cancer. But historically, ovarian cancer has been, what we've termed as kind of the deadliest gynecologic cancer. And the majority of our patients are diagnosed at a late stage, and that's stage 3 or 4. And typically 5-year survival rates are around 50%.
And just so that we're all clear, does an early detection screening test exist for ovarian cancer in the way that it exists for cancers such as breast and cervical?
Rachel, that's a great question. Unlike, breast cancer, where we have mammograms, and cervical cancer, where we have a pap smear, or HPV now, which is replacing the pap smear, we don't have anything very specific, that has been proven to reduce your detection of early stage disease. And, ultimately the goal is to reduce your risk of dying from the disease, like for any good screening strategy, right? And we don't really have that in ovarian cancer. And so we actually do not recommend that, the general population get screening with ultrasounds or even a blood test called a CA-125. And, the reason for that is studies have shown that, doing these tests actually, may cause harm, and that you may undergo unnecessary surgeries.
Where do we think the disease originates, and why is it so difficult to detect?
Yeah, that's a great question, Rachel. So, we actually think that ovarian cancer originates in the fallopian tubes. And that's one of the reasons why we advocate for removal of your fallopian tubes in women who are undergoing hysterectomy or needing surgical sterilization. And the reason that, it's so difficult to detect is that we don't have effective screening methods to detect ovarian cancer. And, although we have ultrasounds and, CA-125, the prevalence of ovarian cancer is low. And so when you look at these screening tests, we have not found them to be effective in diagnosing ovarian cancer at an early stage, which is what you want for a screening test. And the other reason that it's so difficult to detect is the symptoms are extremely vague. And so by the time a patient recognizes the symptoms, they're usually, at a more advanced stage.
Great. Thank you so much. So, Dr. Randall, what are the symptoms of ovarian cancer, and what should we do if we are experiencing these symptoms?
Well, thanks for that question, Rachel. It's really important to know the symptoms, but like Dr. Pothuri mentioned, unfortunately, many women are not symptomatic until things are getting into a more advanced stage. So that makes knowing the symptoms all the more important, because the sooner you can report those to your doctor, the better. So most of the symptoms are abdominal. and they include bloating or distension or swelling of the abdomen. One very specific symptom is that patients will notice they feel full soon after they start eating. And that's not normal. I mean, I don't know about you. I love to eat, so it's very hard for me to stop eating. And then the patients will notice, if I take 2 bites and I'm full and I don't want any more to eat, then that's definitely a red flag. And I think the difficulty of these symptoms, bloating, distension, they can be caused by other things, things that are not ovarian cancer related at all. And so oftentimes when you go to the physician and you mention these symptoms, they may try some things that have nothing to do with cancer. They may try you on medications that are for indigestion, or they may wait to do any sort of imaging. But the key to these symptoms is that they're persistent. They're not going to go away. They get worse over time instead of better. They don't respond to any of these treatments. So I've been in practice for a long time. I have a lot of patients who will say, "Oh, I went to my doctor and I said I had these symptoms, but they gave me antacid and told me to go away." Well, it was okay to give you an antacid, but when it didn't help or then you have to follow up and you have to go back. And if they are persistent symptoms, then you need to stay on top of that. And if your doctor won't look into your symptoms further, then maybe get a second opinion.
Yeah. I just personally think it's important that we highlight that, especially as women, just trusting your gut. I mean, I'm no doctor, but really trusting and knowing your body, because only you know your body. So, I agree with that 100%. And I think just not being a doctor, the whole white coat syndrome, we feel that perhaps if you tell me I'm fine, then I should believe that. But I would hope you guys can encourage whoever's listening that, yes, you are doctors and you went to school for a very long time and know a lot of things, and people should trust their instinct. With that said, are all ovarian cancers the same? And if not, what are the different types?
That's another great question. There are a lot of different types of ovarian cancer. And when you Google ovarian cancer, typically you get information about the most common type, which is the epithelial type. It's the type that Dr. Pothuri was speaking of. And that's certainly what we spend most of our time taking care of. But there are some more rare tumor types, and they include tumors like they're called germ cell tumors that can actually arise in young women. These typically come up in one ovary. They're often curable. So when you Google ovarian cancer and read these statistics, they don't apply to every type. So germ cell tumors are one of those types that is potentially curable and not necessarily the deadliest gynecologic cancer. There's another type called a sex cord stromal tumor, which additionally is much more treatable in general than the more common ovarian cancer types. So there definitely are different types. The prognosis and treatment is highly dependent on which type that you have.
Amazing. Thank you. And are there ways to reduce your risk of developing ovarian cancer? You can do that one too, and then I'll pass it to Dr. Pothuri.
That's great. There absolutely are ways to reduce your risk. So number one, for me, the number one way to reduce your risk is that we know that about a quarter of ovarian cancers are hereditary. So know your family history and know if you're at risk for inherited ovarian cancer. And if you have a family history that does have breast cancer, ovarian cancer, prostate, pancreatic cancer, that you're tested for the BRCA gene. If you have a family history that's suggestive of uterine cancer, colon cancer, ovarian cancer, or urinary tract cancers, that could be something called Lynch syndrome. If you don't know, and this is overwhelming amount of information, but you do know that you have a family history of cancer, that's all you need to know to go to your doctor to see if you qualify for genetic testing. If you do test positive, you may be a candidate for risk-reducing surgeries. That's probably the most effective way to reduce the risk. After that, patients who have used oral contraceptive birth control have a very reduced risk of ovarian cancer. We know that 10 years of risk can reduce, or 10 years of use can reduce your risk by up to 90%. And that reduction lasts a lifetime. It doesn't just happen while you're on the birth control pill. It can persist on in life.
Amazing. Thank you. That's good to know. So let's see. I'm going to give you this, Dr. Pothuri. Can you explain the value of seeing a gynecologic oncologist specifically after an ovarian cancer diagnosis?
I think it's really important to seek care from a specialist in GYN oncology. And that's because we spend additional years training just to take care of this disease. And there are studies that have shown that women who are treated at a tertiary care center, meaning a center where there are specialists who can, who know about ovarian cancer, actually have better outcomes, meaning that they live longer. So it's really a no-brainer that, you know, any woman who is diagnosed with ovarian cancer, and even if they're diagnosed with ovarian cancer and they're not going to have surgery immediately, they should see a gynecologic oncologist before they even proceed with neoadjuvant chemotherapy if they're seeing a medical oncologist, you know. And it's something that, you know, you can talk to your doctor about and say, hey, you know, can I see a GYN oncologist to make sure that I don't need surgery first? And those are actually part of the ASCO recommendations when you're diagnosed with ovarian cancer. So it's, as I said, it's really critical to seek the opinion of a GYN oncologist because your outcomes are better.
Right. And Dr. Randall, I guess what qualities would you look for in a gynecologic oncologist?
Well, I mean, everyone wants a nice, approachable, friendly doctor. But I'll tell you, for this, especially, like, you really need someone who's skilled. You need someone with training and experience, just like Dr. Pothuri mentioned. It is a game changer to have a doctor who is skilled in this. It's not a common disease, thankfully. And so if you don't specialize in it, you just can't get really good at it. GYN oncology is so great because most of us, or many of us, provide both surgical and chemotherapy care to our patients. And so sometimes, you know, one is better than the other, and sometimes a combination of the two are important. And if you do both, I think personally, and we have great medical oncologists that take care of ovarian cancer, but if you are able to provide both, I feel like you're less biased as to which a patient should get, and it helps you become very, very patient focused. But I think the number one quality is skill. But you do want your doctor to be very approachable. These are shared decisions. There are multiple options. You know, one option may be right for you, or you may have a barrier to treatment that you need to be able to share with your physician and feel heard and seen, so that you can address that barrier so that you can get the best care. So I think, you know, it's really important to have a well-rounded physician.
So I would just love for either of you to suggest where, number one, to find a gynecologic oncologist, and two, how do we decipher if they're skilled to support us on this journey?
Yeah, I think that's a great question, Rachel, and really, you know, really important, right? You're given this diagnosis. It's so super scary. You don't know where to go. So my advice, you know, is to look for an NCI designated cancer center, and you can just Google that. And most NCI designated cancer centers have, you know, experts. So, and then you can find a gynecologic oncologist in one of those centers that's close to your home. And the other thing that these centers, you know, offer are access to clinical trials, which, you know, are super important in terms of providing, cutting edge care in terms of ovarian cancer. So, having these at your fingertips is really important. And so if you can really, locate one of these centers that's close to your home, that's what I would recommend.
Amazing.
Dr. Randall, do you have other thoughts as well?
Yeah, I agree with you. I think the NCI centers are the best place to start because of the expertise, because of the clinical trials for sure. There are centers outside of the NCI designated centers that do provide ovarian cancer care. I think again, it's just going right back to that question that you asked before, Rachel, that gynecologic oncologist, having that person as, the quarterback on your team is really important. And so sometimes you can find a GYN oncologist outside of NCI designated centers. I think that's like the very best place to start. Um, Patients are getting more and more savvy. Like they're able to look for these, where can I go on a clinical trial? Where are these NCI centers? I think patients are becoming much more savvy at finding these. Patients are organizing. There are different ovarian cancer websites. Tina's Wish is one of those. The Society for Gynecologic Oncology, or the SGO, has a website that lists providers and patient. You can search by your area. So it can be a little bit overwhelming too, the internet, right? Because you get some bad information with the good. But I think that NCI centers, GYN oncologist, clinical trials, focusing on those capabilities is the best way to pick the site for you.
And a thought that came to me too, I'm sure there are stigmas related to clinical trials, if I'm honest, as African-American person, knowing that Black people's bodies were tested on in this country, there's an aversion to that. So if you could just cover, your point of view. And I know, Dr. Pothuri, you are a medical director in the clinical trials office at NYU Perlmutter Cancer Center and the director of diversity and health equity for clinical trials, which is important for people to know as a person of color, and at the Gynecologic Oncology Group Foundation. So if you guys can just kind of speak to maybe possibly the stigma around clinical trials so that people hearing this can feel safe to enter them, or if there's, or some are better than others, or how they would feel comfortable joining.
Yeah, Rachel, that's so near and dear to my heart. So
Me too.
that whole question. Yeah. And I just want to start by, breaking it down. Why participate in a clinical trial, right? Well, two things. One, it gives patients access to novel therapies that have not, that they couldn't otherwise get. And it gives patients hope. So, having the ability to participate in a trial, it becomes, it almost is an honor, because you not only are you getting something out of it by having access to these novel therapies, but you're contributing to the knowledge where, thousands and, hundreds of thousands of other women may benefit from these findings. So, and I just, and I know there's a lot of stigma associated with it, given Tuskegee and, what has happened in the past. But I just want to highlight that, we've come a long way since those times. And, clinical trials are, so scrutinized, where patient safety is of utmost importance. And, everything we do for patients on a clinical trial is always, making sure the patient is safe. So I think, we need to educate our patients about this. And I just want to share just like a small, kind of, experience, given that I am at NYU, and we actually partner with Bellevue Hospital, which is the oldest public hospital in the country. And what we did was we partnered with a dedicated navigator there. And what we were able to do, and that navigator screened for us. So they would screen the charts from the computer, never having seen the patient. And they would identify patients and they would send them to the clinical team. And then we would approach patients with clinical trials. And by doing that, what we did was we increased our screening by 2.5-fold, and we increased our our clinical trial accrual by threefold. And that was just over a 6-month period. And then what we found that was most interesting was that all the patients that we accrued to clinical trial were of diverse races and ethnicities. And so by instituting this, screener, we took away any physician bias. So, just like the patients have their own bias and stigma, physicians have their own bias and stigmas, thinking that, oh, this patient, will not be able to come in for all the trial visits, or they're not going to want to participate in a clinical trial. And the physician doesn't even offer the patient the clinical trial. Right. And studies have actually shown that when we offer patients clinical trials and we give them the explanation of why it's important and how we are going to change the way we treat ovarian cancer, by participating in these clinical trials, and how we bring new medicines to our patients, and the benefit to the patient themselves of being able to have access to these cutting edge therapies. We find that most patients actually want to participate. So it's kind of on both ends that we see these stigmas and biases. I just wanted to share that because we've actually shown that this, these kind of interventions are important. And then you bring up a really important, point that it's also important to have people on your teams that look like you, have people of color, to explain these things. There needs to be some shared experience that, people can connect to really understand that these trials are safe and they are in the best interest of the patient. So these are all kind of, initiatives that, I am trying to spearhead both at NYU, but also nationally, with the new hat that I'm wearing in terms of the, Director for Diversity and Health Equity for Clinical Trials. And I know that Dr. Randall is also super passionate about this, and she's also at a center where this is prioritized. So I would love to kind of also hear her perspective.
Yeah, thanks, Bhavana. I couldn't agree more with everything that you said. And, I actually came to Virginia Commonwealth University, or VCU, in Richmond, Virginia, as a person trained to do clinical trials, as an investigator who noticed the terrible disparity that we have in our clinical trial enrollment and how it was getting worse. And you mentioned African American, Rachel, for our Black patients. It used to be that we would enroll about 10 to 15% of patients on any given clinical trial for cancer would be Black. And that rate has gone down to about 5%. And the reason that that's bad is because we're developing all these new, amazing treatments, and these patients are being left behind. They're being left out. And they're missing out. They're missing out on a lot of things. They're missing out on getting tomorrow's treatment today, just like Dr. Pothuri mentioned, but they're also not being counted. So when this drug that was only tested in one type of person, basically affluent white patients, not rural white patients, not Black, not necessarily Asian, and different types of Asian ethnicities, that drug gets approved, it may not work for everyone. It may have different side effects for different groups. And so we're not going to pick that up in our clinical trials if we only enroll one type of patient. And so then that drug gets put out, and then that becomes the standard of care. And then we start doing a clinical trial, meaning I start just using it in my office, but it's not really well tested in that specific group. Sometimes we don't really know what to expect. And so really, to be honest, I hate the term clinical trial because it sounds so scary. It sounds so experimental. It really sounds like you're going to hook someone up to electrodes, or I just hate the term because it's intimidating. But every time we give a patient a cancer treatment, truly it's a clinical trial. We don't know if it's going to help them. We don't know what kind of side effects they're going to have. And whether, only difference is how much prior information that we have. But we may not even, when we're talking about diverse populations, we may not even have that information available for those patient groups. So that's where it becomes really important. So to me, it's an injustice not to be on a trial.
And I think the last thought I had in this on this topic would be, what if you aren't in New York City, or you're not in San Francisco, or some big coastal city that has all of these resources? What do those people do? And more specifically, if you find out about a trial that's not located near you, is there funding to have them come be a part of that trial wherever that trial exists?
Thanks to Dr. Pothuri, there's funding.
Because I'm sure you're a lot of people, to your point, of anywhere from rural white to Black to just, I'm in Green Bay or wherever. Maybe Green Bay has an amazing cancer center I don't know about. But, as city dwellers, we lose sight of our privilege to have access across the board. So I would just like to inject hope and opportunity for those people that can't attend NYU down the street from them,
Yeah, no, that's a really important and great point, Rachel. And, I think one of the easiest ways to know what trials are open or available, clinicaltrials.gov. And, patients can search that as well as physicians. So that's a really, simple way. And then once you can put in your disease site, and then options for different trials will pop up, and you can put in your location. So because all the trials that are open are listed on that, and so you will be able to identify a trial that and then once you've identified that, you reach out to that institution and say, hey, I'm interested, because there usually will be a contact number, and then they will help guide you.
Well, before we close, is there anything else that has come up that either of you want to share with our audience? Or closing thoughts, Dr. Randall?
I just want to thank you, Rachel, for bringing this up to light and having this conversation. Here we thank Tina's Wish Foundation for carrying on this conversation. If this doesn't reach the people that need to hear the message, then what we do is not quite as effective or as important. So right. Thank you so much.
Thank you. And Dr. Pothuri?
I would like to echo everything Dr. Randall said. Yeah, thank you for allowing us to, voice what we do and educate and really empower all our patients. And I just want to say that, it's a really exciting time to be in GYN oncology. Just in ovarian cancer, there have been, 14 new drug approvals, over the past decade. And, that's more than in the past 60 years. So there is definite, hope. We are making progress. We know patients are living longer with ovarian cancer, because we do see the prevalence going up, and that's really because, patients are living longer.
But the incidence is going down, and I think that we're starting to see some effects of our prevention.
Yes.
With our removal of the fallopian tubes, like you talked about, removing the ovaries and our genetic risk patients. Like, I think we're starting to see an impact there. So that's really exciting.
And I want everyone to, advocate for themselves, listen to your bodies, as you said. I always say, you have to be your strongest advocate.
After hearing from Doctors Pothuri and Randall, I am even more convinced why Tina Brosman's wish for an early detection for ovarian cancer is also my wish. Every woman deserves to have a fighting chance against this disease. Now it's time to wrap up. Next to the live stream in the chat box, you will see a link to the post-webisode survey. We hope that you will take 30 more seconds to share your feedback with us. A huge thank you to Dr. Pothuri and Dr. Randall. We truly appreciate your time and all that you do to improve the lives of women. A big thank you to all of you for tuning in and for your incredible support of Tina's Wish and our initiatives. As I mentioned, the Tina's Wish team will address questions from the chat box in the follow-up email blast that they send out after this webisode. That email will also contain the full recording of this session and the link to the podcast version. Stay tuned for more information about our next webisode. Be well, take care, and please be your own best health advocate.